Namaste, I am Dr. Rahul Basnet working at Tulikhel Hospital, and today I am going to be making a video on upper GI bleeding. Yo video chahi, it's not going to be a long comprehensive video, rather it's going to be like a revision video which you can look at before your exam. Ekdam rapid revision ko लागि matra ho, and it's not going to be a substitute for your standard textbooks. त्यही भएर एकचोटि चाहिँ सबजनाले स्ट्यान्डर्ड टेक्स्टबुक पनि पढ्नु होला. To start with the approach, we have to know the history, examination, investigation and treatment of the cause. अब त्यसको लागि चाहिँ कजेसहरु के हुन सक्छ त बटै सुरु गरौँ है त. So what is upper gastrointestinal bleeding भन्दाखेरि first we have to know what is the upper gastrointestinal tract. It is the part of the gastrointestinal tract which lies proximal to the ligament of Treitz. Ligament of Treitz. Ligament of Treitz चाहिँ नि हाम्रो duodenojejunal flexor देखि हाम्रो right cross of the diaphragm लाई join गर्ने एउटा ligament हो. And bleeding which occurs from anywhere of the GIT proximal to that point is defined as upper gastrointestinal bleeding. Now, the etiology can be classified according to make it easier, we can either classify it according to anatomy, like whether it starts from the esophagus or whether it's coming from the stomach or whether it's coming from the small intestine, or we can classify it according to incidence. Incidence ko लागि चाहिँ नि I would recommend everyone to study Harrison's table because it is सबभन्दा हाम्रो standard textbook त्यही हो medicine को लागि. And according to Harrison's table, most common cause of upper gastrointestinal bleeding are ulcers, which account for 31 to 67% of the causes. Now, we all know peptic ulcer disease can be a whole separate topic, 1 hour long. So in this topic, we're only discussing very short points. The common causes of peptic ulcer disease are H. pylori, NSAIDs, other drugs, smoking, alcohol. अब यस्तो हिस्ट्री लिएर आउने पेशेन्टहरुमा चाहिँ नि we have to suspect if there is any peptic ulcer disease. So any patient presenting with upper GI bleeding and has a history of these, we have to strongly suspect peptic ulcer disease. The second most common according to Harrison's is esophageal varices. Esophageal varices चाहिँ नि it occurs when there is portal hypertension. Again, this can be another separate topic, so here we'll discuss it only shortly. In case of portal hypertension, as the lower esophagus is a meeting anastomotic point for the systemic and portal vessels, it has a high chance of bleeding in case of portal hypertension. The third common cause according to Harrison is Mallory-Weiss tear, which accounts for 2 to 8% of the causes. Mallory-Weiss tears are longitudinal ulcers in the lower part of the gastrointestinal tract. We have to suspect in those patients who have a history of retching and may have dry vomiting, just retching, and then there may be upper GI bleed, hematemesis. So in those patients, we have to suspect Mallory-Weiss tear. Then the next causes are esophagitis or gastroduodenal erosions, and finally neoplasms, 1 to 13% and 2 to 8% respectively. Now the rarer causes are something called as the Cameron lesions. Cameron lesions भनेको चाहिँ नि they are ulcers which occur in the sac of the hiatus hernia. So this is the sliding hiatus hernia, this is the diaphragm, and ulcers in the hiatus hernia, when they bleed, they are known as Cameron lesions. Then the next can be Deulofeu lesions. These are actually aberrant submucosal vessels. Submucosal vessels which erode the mucosa and then bleed. And another one rare cause could be GAVE, that is gastric antral vascular ectasia. It is also known as the watermelon stomach. and it is commonly associated with systemic sclerosis. Now, the other causes could also not related to the GI tract, could be bleeding disorders, drugs, and spurious hematemesis. So now, after knowing few of the causes, we can go to the approach. Approach चाहिँ always history, examination, investigations, and treatment. Now, first we begin with the history. So any patient presenting to our emergency room अथवा हामीले चाहिँ अब वार्डमा लिएर आउँछौँ हिस्ट्री हैन, so they will present with a history of either hematemesis or melena in case of UGI bleeding. And sometimes may present with hematochezia as well. Melena is defined as passage of blackish tarry stool, and there must be at least 60 to 80 ml of blood, which must remain for at least 14 hours, which is according to Harrison. And the blood gets digested by acid hematine, resulting in black colored malodorous stool. Clinical features only become evident when there is at least 500 ml of blood loss. So if there is less than 500 ml of blood loss, there is a thing known as occult blood in the stool. Occult blood ko लागि चाहिँ it is positive only if there is at least 2 ml of blood loss per day, also known as the Guillac test. And for this test, it is usually recommended that we take 3 consecutive days of meat-free, high-fiber diet with low vitamin C and no NSAIDs. Now, to go to history proper, we have to first ask how many episodes of the UGI bleeding were there, what is the frequency, what was the amount, and then we have to go look for the causes of the upper GI bleeding, which could be alcohol, smoking, drugs. Drugs most commonly are NSAIDs and steroids, and others could be antiplatelet and anticoagulant drugs. अब यो सबैको हिस्ट्री along with heartburn, water brash, अनि त्यस्तोको हिस्ट्री दिएछ भने चाहिँ we have to strongly suspect peptic ulcer disease as our most probable diagnosis. Next, we also have to look for history of retching. If there is presence of retching and upper GI bleeding, then we have to suspect Mallory Wiestier. History of dysphagia along with weight loss. Then we have to suspect neoplasms. Neoplasms, it can be either esophageal carcinoma or gastric carcinoma. Now talking about esophageal carcinoma. Esophageal carcinoma most common is squamous cell carcinoma, most prevalent around the world. But अहिले चाहिँ incidence of adenocarcinoma is increasing. And squamous cell carcinoma को most common site चाहिँ middle 1/3 मा हुन्छ. 50% is in the middle third, 30% चाहिँ lower third मा हुन्छ. And adenocarcinoma चाहिँ नि invariably lower third मा हुन्छ है. त्यही भएर even though squamous cell carcinoma चाहिँ most common हो and occurs in the middle third, but esophageal carcinoma overall most common चाहिँ नि lower third मा हुन्छ है. Because squamous cell carcinoma पनि 30% lower third मा हुन्छ and all of the adenocarcinoma is in the lower third, so lower third is the most common site. Now going for other history taking में अरु कुराहरुको लागि चाहिँ अब हामीले most commonly rule out पनि त्यही अनुसार हिस्ट्री में अरु कुराहरु पनि rule out गर्ने अनि हामीले चाहिएको कुरा पनि हामीले rule in गर्न पर्यो है. Now going for the examination. Examination always begins with the general condition, vitals, pill code, and त्यसपछि बल्ल examination proper मा आउँछ हामी. अब in this case vitals are very important because UGI bleeding भएर सकमा आइरहेको हुनसक्छ पेसेन्ट, एन्ड द्याट इज अ रेड फ्ल्याग साइन. सो वी हेभ टु लुक फर ट्याकिकार्डिया, हाइपरटेन्सनमा चाहिँ बोथ एक्चुअल हाइपरटेन्सन एन्ड पोस्चरल हाइपरटेन्सन पनि हामीले चेक गर्नुपर्ने हुन्छ. एन्ड देन वी हेभ टु लुक फर अब युरिन आउटपुट to rule out other signs of shock. Also, we have to look for the stigmata of chronic liver disease. So त्यो हेड टु टो जुन हाम्रो एक्जामिनेसन हुन्छ लिभर डिजिजको, त्यसमा चाहिँ सबै कुरा इन्क्लुड गर्नु पऱ्यो हामीले यसमा. या माथिबाट अब टेम्पोरल बल्डिङ, एलोपेसिया, टेम्पोरल फोसा अलोइङ, जन्डिस, प्यारोटिडोमेगाली, नेकोमास्टिया, स्पाइडर नेभी, अनि हाम्रो असाइटिस, स्प्लिनोमेगाली, क्यापुट मेडुसी, peripheral leg edema, dupuytren's contracture. We have to look for all the stigmata of chronic liver disease. After that, after we complete the history and examination, we will go for the investigations. Investigations will be next. So, in case of investigations, in case of UGI bleeding, blood investigation we will look for blood grouping and cross matching. It's only because people may be in severe anemia. Our long standing UGI bleeding ma pani severe anemia huna sakcha, or severe acute bleeding ma pani anemia huna sakcha. So we'll have to go for blood grouping and cross matching. We will have to look at the hemoglobin and hematocrit for any anemia. And usually if 7 gram per dl bhanda kam cha bhane it is an indication for transfusion. We will have to look at the platelet levels. And PT-INR is also done to know if there is any bleeding disorders or if the coagulation profile is disordered due to use of drugs. PT-INR is also done. And एउटा एकदम important investigation in case of UGI bleeding is urea and creatinine. It also helps to separate between UGI bleeding and LGI bleeding, because in case of UGI bleeding, the blood urea is very much elevated, and the ratio is usually urea to creatinine is more than 72. यो चाहिँ किन हुन्छ भन्दाखेरि in case of UGI bleed, the blood is digested by the small intestine, and the proteins get absorbed from the blood, so urea is raised. Is an important concept. Then LFT ko लागि त हामीले we have to look for chronic liver disease ko anything केही साइन्सहरु केही देखिन्छ कि भनेर हैन. And then another special investigation which is not done in other cases is putting an NG tube, doing NG aspiration and lavage. Lavage in case of UGI bleeding is done with tap water ले नै गरिन्छ 500 ml जति. It is not only diagnostic but also it has some kind of therapeutic role, and it is also used for monitoring if there is any further bleed. Go for the treatment of the cause. We have gone through the etiology, सबै कजहरु के हुन सक्छ हामी डिस्कस गर्यौं. देन हिस्ट्रीमा के सोध्ने, एक्जामिनेसनमा के गर्ने, एन्ड इन्भेस्टिगेशन्स व्हाट वी विल सेन्ड वी हैव डिस्कस्ड. नाउ वी विल डू व्हाट वी डू इन द ट्रिटमेन्ट. अब एउटा क्वेशन कमनली सोधेको पहिला चाहिँ नि युजिआई ब्लिडिङ भएर पेशेन्ट आयो, एन्ड देन व्हाट वुड यु डू इफ यु आर इन अ प्राइमरी हेल्थ सेन्टर एन्ड व्हाट वुड यु डू इफ यु आर इन अ टर्शियरी हेल्थ सेन्टर भनेर क्वेशन आउँछ है. त्यो गर्नलाई चाहिँ अब इनिशियल फेजेस चाहिँ नि सबैमा सेम नै भइहाल्यो. हिस्ट्री, एक्जामिनेसन, इन्भेस्टिगेसन सबैमा सेम हो. देन वी हेभ टु गो फर रिस्क स्ट्राटिफिकेसन विच क्यान बी डन बाई डिफ्रेन्ट स्कोरिङ मेथड्स. त्यो मेथड्स चाहिँ नि हाम्रो एउटा रकल स्कोर भन्ने हुन्छ, एउटा ब्ल्याचफोर्ड. यो चाहिँ हामीले वी डोन्ट हेभ टु नो इन डिटेल, वी जस्ट हेभ टु नो द नेम्स अफ द स्कोर्स विच क्यान अल्सो बी आस्क्ड इन द भाइभा. द्याट्स वाइ रकल, ब्ल्याचफोर्ड, फोरेस्ट क्लासिफिकेसन हुन्छ पेप्टिक अल्सर डिजिज ब्लिडिङको लागि, एन्ड देन वी हेभ M65 स्कोर. स्कोरिङहरू हुन्छ. अब ट्रिटमेन्ट चाहिँ नि इमिडिएटली वी हेभ टु बिगिन इन एनी केस. ट्रिटमेन्ट भनेको हाम्रो फर्स्ट ट्रिटमेन्ट भनेको अलवेज ABC हुन्छ, एयरवे, ब्रिदिङ एन्ड सर्कुलेसन. एयरवेमा चाहिँ नि इन केस अफ युजिआई ब्लिडिङ इट इज भेरी इम्पोर्टेन्ट टु सेक्योर द एयरवे, बिकज most commonly चाहिँ नि पेसेन्टहरू UGI bleed भएर they aspirate the blood and then they have secondary respiratory complications. त्यही भएर we can do intubation to secure the airway. Next, circulation is very important as well. We usually open two lines with either 14 gauge or 16 gauge को cannula ले 2 lines open गर्नु पर्यो and immediately fluids चाहिँ नि हामीले start गरिहाल्छौँ है त. Talking of the fluids, if you're in a PHC, we can't धेरै fluids त हुँदैन, NS RL हुने हो. So we usually go for normal saline. Normal saline चाहिँ नि we can give 20 ml per kg, which can be repeated once. And maximum चाहिँ नि 2 liters सम्म चाहिँ दिन मिल्यो है. We don't go for over expansion because over expansion can cause increase in the bleeding. त्यही भएर चाहिँ नि 2 liter भन्दा बढी चाहिँ usually सुरुमा चाहिँ नि बोलस चाहिँ नि दिदैन हामीले है. Next, ABC secure भइसक्यो. Then what we can do is we can give injection vitamin K 10 mg IV stat. This can also be done in any PHC or vitamin K ta hamro pairakai huncha, so it can be done. We can give intravenous proton pump inhibitors. Usually most common the peptic ulcer disease नै हुन्छ, so unless it is ruled out we have to give IV proton pump inhibitors. And then prophylactic antibiotics पनि if available we can give. If not, यति गरेर चाहिँ नि we refer to the tertiary center. अनि tertiary center मा पनि we do the same things as mentioned above. We secure the airway, we give oxygen, then we secure the IV lines, and we start with the fluids. But extra thing that can be done in the tertiary centers are, because of the available resources, we can also transfuse PRBC if the hemoglobin is less than 7 gram per dl. We can give platelets if less than 50,000 with active ongoing bleeding. We can use fresh frozen plasma if the prothrombin time is more than 15 seconds or INR is more than 1.5 times the normal. And FFP र platelet चाहिँ for every 4 pints of PRBC, 1 FFP can also be used है. त्यति गरिसकेपछि चाहिँ नि first and foremost step in the treatment is hemodynamic stabilization. In any case, hemodynamic stabilization is most important. And in case of UGI bleeding, because we have to do UGI endoscopy to find out the cause and do the definitive treatment, it is very important that we do the hemodynamic stabilization first. Now, after doing the hemodynamic stabilization, and once we get to know that idea whether it is A, variceal bleeding, or B, non-variceal bleeding, यतिको चाहिँ हामीले idea हुन्छ after doing all the history, examination and investigations. So now we will do first the treatment of non-variceal bleeding. As I said earlier, the definitive treatment is always endoscopy and then proceed and treat whatever is the actual cause. But we have to also look before the endoscopy. First मा चाहिँ pre-endoscopic चाहिँ के गरिन्छ त? Pre-endoscopic we have to give IV proton pump inhibitors, usually 80 milligram bolus, followed by 8 mg per hour infusion. Obviously, first step is hemodynamic stabilization. Second step is the IV proton pump inhibitors. IV PPI ko advantages चाहिँ नि, it can help to enhance the clot stability, which will then prevent further bleed. And the goal of this is to maintain the pH more than 6. Then once the patient is hemodynamically stable, we go for the endoscopic treatment. Endoscopic treatment in case of non-variceal bleeding the cause is usually peptic ulcer disease. So for peptic ulcer disease, what we can try is epinephrine injections. We can go for thermocoagulation, or we can go for clipping and hemosprays. Hemosprays are हाम्रो TC325. Now we also have to know the risk factors for rebleeding. यस्तो भयो भने चाहिँ नि हामी cautious हुनुपर्छ, and we have to immediately do endoscopic retreatment है त. So the risk factors for rebleeding are if we see any sentinel clots during the endoscopy, or if there are any exposed blood vessels. In these conditions, we should always be cautious. And finally, after the endoscopy also we have to do post-endoscopic treatment. Post-endoscopic ma chahi ni whatever the cause of the peptic ulcer disease might be. So if it's H. pylori, we have to go for H. pylori eradication. If it's just peptic ulcer disease, we have to go for proton pump inhibitors. We have to continue even after the endoscopic treatment. Then we have to stop the offending drugs if it's NSAIDs or steroids, and we have to look for alternative drugs. We have to stop smoking and alcohol. It's strictly prohibited. H. pylori eradication ko लागि चाहिँ नि हाम्रो there is a triple therapy regimen and a quadruple therapy regimen. Triple therapy मा चाहिँ नि एउटा lansoprazole, amoxicillin र clarithromycin को छ, or there is a bismuth subsalicylate, metronidazole and tetracycline regimen. यसमै चाहिँ हामीले if we add a PPI, it becomes a quadruple regimen. So यो पनि एकदम important to remember for all the undergraduate students. So this is the treatment if we find a non-variceal bleeding. Now talking about the treatment of a variceal bleed. Treatment of variceal bleeding चाहिँ नि अब endoscopic as well as drugs को चाहिँ एकदम ठुलो रोल हुन्छ यसमा चाहिँ. फर्स्टमा चाहिँ urgent stabilization and resuscitation नै हो यसमा पनि. In any case of UGI bleeding, in any bleeding, हाम्रो first management is hemodynamic stabilization. यसको लागि हामीले फर्स्टमा इनिशियली गर्ने blood transfusion, fluids or सबै दियो अघि जस्तै as mentioned above. Then vitamin K, PPI को कुराहरु पनि as mentioned above. And the most important drugs in case of variceal UGI bleeding are the vasoactive drugs. Vasoactive drugs मा चाहिँ हाम्रो usually दुईटा को कुरा हुन्छ. They are terlipressin and octreotide. Terlipressin को dose चाहिँ नि 2 mg 6 hourly it's given, but as it is a very potent vasoconstrictor, it is contraindicated in case of ischemic heart disease and hypertension. It is initially given 2 mg 6 hourly, and then after the bleeding stops, it's given as 1 mg 6 hourly for 72 more hours after bleeding stops. And in case of octreotide, it's given as a 50 microgram bolus dose, followed by 50 microgram per hour for at least 2 to 5 days. Next, what we do is we give prophylactic antibiotics. Usually it's cephalosporin or neomycin is given. And the role of antibiotics is to prevent spontaneous bacterial peritonitis and to prevent rebleeding. Now, if it's a variceal bleeding, the patient may also have other complications of liver cirrhosis. And take complications which might be more life-threatening, like we have to address at this point. Like if there's any hepatic encephalopathy, hepatorenal syndrome, then we have to address at this point. Next step for the treatment of variceal bleeding would be urgent endoscopy. And the best outcome is achieved if the endoscopy is done within 24 hours. So हामीले जुन पनि अगाडिको hemodynamic stabilization and everything else that we need to do, we have to do before the 24 hours. Most preferred method of endoscopic treatment for variceal bleeding is variceal bind ligation. And if it's not possible, then the other option which can be tried is the endoscopic sclerotherapy. Sclerosing agent पनि एकदम commonly हाम्रो MCQ मा पनि सोध्न सक्छ, and it can also be asked in vivas. So some of the common sclerosing agents are ethanolamine oleate, absolute alcohol, sodium tetradecyl sulfate, cyanoacrylate. And in one MCQ it was asked which of the following is not the sclerosing agent, and त्यसको answer चाहिँ acetic acid is not the sclerosing agent है. अरु अघि नै भनेको चाहिँ they are examples of the sclerosing agents. अब यही दुईटा मध्ये एउटा अप्सनमा कन्ट्रोल भयो भने चाहिँ नि we just continue with the vasoactive drugs as discussed above, like terlipressin or octreotide चाहिँ continue गर्ने. And to prevent bleeding चाहिँ नि prophylactically we can use beta blockers. Continue the vasoactive drugs, and then addition of beta blockers can be done. Now if यो दुईटा अगाडिको 1 and 2 fails to control the variceal bleeding, then we have to look for other options. त्यो चाहिँ के हुन सक्छ भन्दाखेरि फर्स्टमा चाहिँ नि we can do balloon tamponade. यो चाहिँ नि it's not a definitive method of treatment. It's just a temporary method to stop the bleeding. कहिलेकाहीँ चाहिँ bleeding एकदम धेरै भएर in endoscopy we cannot find out the cause. So by doing the balloon tamponade, we can just stop the bleeding and look for the cause. 90% मा चाहिँ it can successfully stop the bleeding, but as soon as we deflate the balloon, the bleeding starts again. So it is not the definitive treatment है त. Balloon tamponade मा चाहिँ we have two options. One is the Sengsteken Blackmore, अर्को चाहिँ Linsen Nyhaus tube हुन्छ. The Sengsteken Blackmore tube is the esophageal tube. यो चाहिँ नि हामीले 40 mm of Hg मा pressure मा चाहिँ we inflate it, but it has to be deflated every 3 to 4 hours मा चाहिँ नि at least once deflate गर्नु पर्छ for 10 minutes. This is done to prevent the esophageal necrosis. अब यो चाहिँ नि हाम्रो स्पटर्सहरुमा पनि सोध्न सक्छ, and it can also be asked in MCQ. यो Sengsteken Blackmore tube मा चाहिँ नि तीनटा lumen हुन्छ. The three lumens are for the one is the gastric balloon, one is the esophageal balloon, and the third is the gastric aspiration port. So there is no esophageal aspiration port, which can be asked in the MCQ. Next, after doing balloon tamponade, then we can our blood clear go and we can know the cause, and we can go for the therapeutic endoscopy. अब यति गर्दाखेरि पनि if there is no cause found and variceal bleeding भइराछ भने चाहिँ नि we can go for transhepatic intrajugular portosystemic shunting. Tips can be done. यसको indication चाहिँ if bleeding persists even after two sessions of endoscopy. Endoscopy in last 5 days. So last 5 days ma दुईचोटी endoscopy treatment for the UGI bleeding is done, but still there is UGI bleeding, then we have to go for transjugular intrahepatic portosystemic shunting. Finally, यसले पनि भएन भने चाहिँ we have to just find out which of the vessel is bleeding by the angiography, and we have to embolize that vessel, which is a very complicated procedure. And केही पनि भएन भने चाहिँ हाम्रो लास्ट option would be the surgery. Surgery-मा चाहिँ नि अब in case of variceal bleeding, it can be esophageal transection. And then in case of peptic ulcer disease, if there is intractable bleeding and अगाडिको हाम्रो non-variceal bleeding मा जसरी ट्रिट गर्ने भन्यौं, if that fails, then we have to go for highly selective vagotomy and gastrectomy or some other surgical method. Variceal को लागि र non-variceal को लागि छुट्टा छुट्टै भइहाल्यो. So that's it, guys. To summarize, हामीले के भन्यौं भन्दाखेरि first we discussed the etiology of UGI bleeding according to the most common ones in Harrison. अनि यसलाई चाहिँ नि as I said we can also memorize as anatomically esophagus मा के हुन्छ causes, stomach मा के हुन्छ, and then small intestine मा के हुन्छ. Then we further approach, we went for history examination investigation. In case of history taking, we did what were the risk factors. हाम्रो अगाडिको जुन कजमा चाहिँ नि रिस्क फ्याक्टर्स हुन सक्थ्यो, so that we know what is the cause of UGI bleeding. Examination मा चाहिँ we focused more if patient is in shock or not. अनि अर्को important aspect चाहिँ नि if there is any stigmata of chronic liver disease. Then investigations मा चाहिँ नि we talked about what investigations we send and why we send them. And finally treatment मा in any case UGI bleeding भएर आउने बित्तिकै चाहिँ नि we have to do hemodynamic stabilization ABC, and then PHC मा छ भने के गर्न मिल्छ बेसिक गर्ने, टर्शियरी सेन्टरमा छ भने चाहिँ नि we have to do everything. First step is always hemodynamic stabilization, and then only we go for endoscopy. Endoscopic treatment मा in case of non-variceal bleeding we can have thermocoagulation, or we can have epinephrine injection, we can have clipping, we can have hemosprays. And in case of variceal bleeding we can have, first and most preferred is the variceal band ligation. If not, we can go for endoscopic sclerotherapy. त्यसमै कन्ट्रोल भयो भने हामीले अब अगाडिकै vasoactive drugs, terlipressin or octreotide जे चलाइरा छौं त्यही continue, and then add beta blocker for prophylaxis. If it is not controlled, then we can go for balloon tamponade. Balloon tamponade गरेर हामीले we can go for balloon tamponade. And balloon tamponade गरेर we can stop the bleeding, we can find out the cause and treat the cause. And if in the last 5 days we do 2 sessions of endoscopic treatment and bleeding still persists, then we can go for TIPSS. Finally, if tips fail, we can go for angiography and embolization of the culprit vessel. And last option is the surgical treatment. So that's all for UGI bleeding, guys. Thank you very much.